Welcome everybody to the forum, our first virtual forum. And we're hoping to be able to actually do more of these as we go forward. And so today it seemed like the most appropriate discussion for us to have was to talk about how COVID-19 affects your breast cancer care and how UCSF is managing COVID-19. And actually, there have been a lot of conversations with everybody as we're have been managing through this. And we've had a lot of leaders within our community who have helped tremendously in how we've set up our guidelines, how we make sure our patients and staff are safe, and what recommendations we've made to our patients also. And we're really fortunate today to have two of the leaders in our cancer center for this area, Dr. Pelin Cinar, and they will introduce themselves as well. Dr. Manisha Israni, and I'll just have them briefly say what they've been doing with the whole COVID-19 work at UCSF and what their jobs are in real life. Pelin.
Hi, thanks for inviting us, Dr. Rugo. So I'm Pelin Cinar. I'm a GI oncologist. I actually focus on pancreatic cancer, but I'm also the medical director of quality and safety for our cancer center. So really try to provide different ways of improving care for our patients, potentially identify opportunities for improvement, and so that we can provide the best possible care to our patients.
And Manisha.
Hi, everyone. Thanks, Dr. Rugo, for allowing me to be a part of this. I am an internist and a pediatrician, and I'm in my previous life, pre-COVID, was a hospitalist, and my relationship with the cancer center is I was, beginning this month, I was going to be the medical director for our cancer acute care center, so the urgent care within the at Mission Bay that opened up. And then with the COVID-19 situation, I transitioned to becoming the medical director of our respiratory screening clinic at the Mission Bay campus, where we see most of our cancer center patients and some other subspecialists. So that's my role currently.
Thanks very much. And I don't think we have Laura or Sarah on yet. Is that right? So we will be joined in a little bit by Laura Esserman, who's the director of the Breast Care Center and a surgeon, our lead surgeon. And she's also been working really hard on trying to protect our patients, and how we're making decisions about surgery and screening will be part of her topic as well. And also some interesting work she's trying to do by using the modeling of our I-SPY neoadjuvant program that we've talked about some in the forum, and seeing how we could use that approach to test many different ways of treating COVID-19. So that's a whole other area that she'll talk about a little bit. And then we're also going to be joined by Sarah Donahue, who many of you may know. She's one of our breast cancer nurse practitioners who talk a little bit about how we're screening our patients and how our nurse practitioners are playing a role in that area as well. So I think with that, we'll go ahead and get started. And Dr. Cinar, or Pelin, we'll use our first names for this forum as we always do, has actually been hosting a huddle call every single morning, I have to say, at 7:45, except for Saturday and Sunday. And she now, just simply because, and she'll talk about this some of the changes in what I think we all feel really congratulatory about, that the Bay Area seems to have less COVID than we expected. We've just changed it to 3 days a week, and I've been fortunate enough to be able to join in on those calls and hear what Pelin has been doing and how she's been leading the group firsthand. So she's going to talk about some now, and she has some interesting slides to show us as well. Pelin.
Great, thank you, Hope. So I think we did the introductions there. So I'll actually move on. I think we're all familiar that COVID-19 started out in December of 2019 in Wuhan City in China as a respiratory illness, and ultimately on March 11th became a pandemic when there were confirmed cases of about 100,000 cases globally. It's interesting to see what has happened since then. We all know, and we all have been affected globally, locally, by this pandemic. But one interesting graphic that we have possibly have seen is the number of COVID-19 cases that have increased since early March, from being the lowest number of deaths contributing to the daily US death number to becoming the highest number currently. And interestingly, when we look at the data from today, we are now at 2 million cases confirmed globally, with 128,000 cases of death, most of which are in Italy, 21,000 in Italy, and 15,000 of them are in France, and 7,000 to 8,000, I would say, in New York City currently. When we look at our data in California, we now have 25,000, close to 26,000 total confirmed cases of COVID-19, with 790 deaths in California. Majority of those are in Los Angeles, 366 deaths. We have about 15 in San Francisco currently. Our UCSF data has shown us that we have a positive test result rate of 3.6%, which is actually quite good considering our colleagues in the East Coast. We've tested about 3,900 patients, and the turnaround time for most of those tests have been around 15 median hours from the time that the test was obtained to when the results were available. We currently have 12 patients in the hospital in acute care, 6 patients in critical care, and 5 patients are ventilated. These numbers have actually been quite stable for the last week or so. We have treated a total of 28 patients with 1 death at UCSF currently. That was not a cancer center patient. A big question that we all have is if social distancing is working in San Francisco, and if that is one of the reasons that has contributed to what we would consider a successful handling of the pandemic. These are some of the slides that I'll share with you from Dr. George Rutherford, who's an epidemiologist and has been really instrumental in providing us with transparency regarding data, but also really counseling the governor and just local politicians in their mandates in regards to shelter in place. You'll notice that when we went into shelter in place around March 17, we hadn't yet experienced the first death related to COVID-19. And that's an important point to keep in mind. That's compared to Los Angeles, when the first death was in the middle to early March. And their shelter in place did not start till later. They started about a week after us. And you can see that the number of cases that they have experienced with confirmed COVID-19 is relatively higher than ours, with thankfully a trending down in the recent week. Now, when we compare Los Angeles to New York City, you can see the dramatic difference. When once again we look at the first death that's related to COVID-19, again in early March in Los Angeles, and in middle of March in New York, you can see that when they went into shelter in place, it was already, there was quite a bit of growth in the volume of cases that were confirmed COVID-19. This is a projection of the peak resource utilization for what was the model for San Francisco. And our peak was supposed to be on April 13th, when the estimate was that we would need 5,000 beds, 820 beds, and we had no bed shortages or ICU bed shortages. So we're hoping that this will continue to be the trend for us. When we also look at the original Imperial College projections, they had projected that 2.2 million deaths related to COVID-19 would be observed in the US, with 264,000 of those in California and 44,000 in the Bay Area. Well, what we've actually observed is that we have 137 deaths. So essentially, they're probably is about 44,000 lives saved because of the shelter in place. And that seems to be the biggest intervention that has taken place that has contributed to that. And I want to share with you what has happened chronologically with us from starting with early February. This clearly does not have granularity of all of the interventions and implementations that we have taken to both at UCSF Health in general and at the Cancer Center. On February 3rd, we actually had two of the first cases in California, confirmed COVID-19 that was transferred to our hospital. On February 25th, Mayor London Breed declared state of emergency. On March 2nd, we started the surge planning at UCSF with implementation of screening guidelines, specifically in the inpatient services at that point. March 4th was when travel restrictions were placed specifically for level 2 and level 3 countries. And on March 6th, we, per the SF mandate, restricted non-essential visitors for inpatient service. And an accelerated care unit opened up on March 8th outside of the ER. And this was in an effort to separate those patients who were suspected of having COVID-19 because they had respiratory symptoms, and separating them from the general population of patients who were seeking care in the ER. March 9th subsequently had the opening of the respiratory screening clinic at Parnassus campus. And Dr. Israni, who's the medical director for the Mission Bay campus for the respiratory screening clinic, will speak about what exactly we do in the RSC, or the respiratory screening clinic. Large gatherings at UCSF were restricted on March 9th. And at that point, we started really encouraging the providers to convert the in-person visits to video visits in an effort to reduce the number of patients who had to come in person in an effort to really reduce exposure to COVID-19. March 9th was also when we started development of our task force in the Cancer Center so that we could develop guidelines and policies that were specific to our oncology providers as well as our patients with cancer. On March 10th, we identified physician champions from the Cancer Center who were selected by the division and department chairs, who, as Hope mentioned earlier, meet with us every morning for a daily huddle. And the COVID-19 inpatient unit opened up at Parnassus to be able to provide those patients who needed to be hospitalized with COVID-19 or suspected COVID-19, and to have a dedicated team members taking care of them. March 16 is indeed when the mandate was from San Francisco for a shelter in place. And prior to that, we had already trained our faculty for the personal protective equipment use, and a hotline was opened up. And on March 20th, finally, our RSC clinic opened up at Mission Bay. So I'll go through each of those implementations and just give you an idea about what it entailed to be able to address the pandemic so that we could continue to provide safe care and continue to provide the care that our patients needed regarding their cancer treatments. UCSF Health Command Center had opened up in February, and we started joining those calls in early March. Similarly, as I mentioned, we also developed our own task force for more cancer center specific guidelines. Daily huddles with cancer center physicians and leaders are led by myself to be able to address the up and coming new guidelines and to keep everybody current, but also to listen to concerns that may have arisen during their clinics and practices to be able to address those. We started pre-screening patients prior to their visits with particular symptoms of concern. Some of those symptoms initially included fever, unexplained muscle aches, respiratory symptoms like shortness of breath and cough. And more recently, additional screening questions have come up, such as headaches, runny nose, sore throat, diarrhea, nausea, vomiting, loss of taste or smell, as well as eye discomfort. And these are some of the symptoms that are quite rare, But nevertheless, we definitely wanted to make sure that there weren't any patients who would be of exposure risk to other patients and our healthcare workers. We also screen patients at the entrance to any clinical area. And once again, we converted in-person visits to telemedicine visits. And these, most of the time, are video visits, but there's also telephone visits for those patients who are not technically savvy or unable to use the video functionality. Patients are now offered and strongly encouraged to wear masks when they're at the cancer center. And as you know, CDC's new guidelines as of early April also recommends face covering when their social distancing is not possible. I know that there were some questions about what does social distancing actually mean. That would be about 6 feet and more of distance between another person around you. Ideally, we don't want patients to be encouraged to be around others when they wear a mask. So even when you wear a mask, we still recommend social distancing at this time and point. Initially, our visitor policy was limited to 1 visitor per visit. And a few weeks ago, we changed that to no visitor policy. It's important to note that there are exceptions to that rule. Clearly, our patients who need special accommodations and special needs, such as those patients with disabilities or dementia, patients with end-of-life issues, we certainly make exceptions for those patients to be able to still provide them with high-quality care. But those visitors are once again required to wear masks when they are at the cancer center. We created the respiratory screening clinic. Once again, Dr. Israni will go into this. And this was in an effort to have dedicated staff in a dedicated unit where we would see these patients with respiratory symptoms, evaluate them, and potentially test them for COVID-19. Our guidelines and algorithms were developed in collaboration with infectious disease colleagues, as well as the ambulatory directors of UCSF Health, so that we could correctly triage our patients to ER, respiratory screening clinics, or for them to stay at home with close monitoring if we felt that they were stable and it was safe for them to do so. We also now have a UCSF COVID positive patient management team. Sorry, that's a mouthful. And that is a team who will notify the patients when their test results are back. They'll monitor the patients every 2 days to make sure that if there's worsening of their symptoms, that this is escalated to the providers. Now, because we have patients with cancer, we're very closely tied to this clinic so that we're aware when there are any issues with any of our patients, whether they got testing for COVID, whether they have any worsening of symptoms, so that we're always aware of what's happening. We also have developed ways that we can treat COVID positive patients in a manner that's safe for both our healthcare workers as well as other patients, but so that we can continue to provide anti-cancer therapy for those patients whose therapy cannot be interrupted. Now, our primary focus has always been and will continue to be that we provide you with treatment without affecting your outcomes, specifically cancer-related outcomes. So very early on, we asked multidisciplinary teams to develop guidelines that were evidence-based and using their expertise to follow specific criterias and algorithms to be able to continue for our patients, knowing that we would have limited resources. Surgeries and procedures were limited early on to only essential, urgent, or emergent cases. Most of our cancer cases were, per those guidelines developed by the multidisciplinary teams, were still under a lot of guidance in regards to when they can be scheduled, and some of them actually proceeded to surgeries. Now, starting this week, actually, we're doing more surgeries, and I'm sure Dr. Esserman will provide us with more information on that. From a systemic therapy perspective, chemotherapy or immunotherapy or targeted therapies perspective, we also, with the advice of our pharmacists as well as the experts in the fields, came up with potential alternative dosing schedules. If there was evidence or data that supported that if a regimen is given every 2 weeks versus every 4 weeks and had the same outcome, then we really wanted the providers to have a say in, to allow for fewer in-person visits to the cancer center or the infusion center. If oral oncolytics or oral chemotherapy drugs were available, we also encourage that for them to be considered. If outpatient care could be in any way transitioned to at-home care, such as some of our patients who have pumps that they go home with, a disconnection of those pumps to avoid coming back to the infusion center, or administration of growth factors or hormone therapy at home. And also increase intervals between the scans. This is once again at the discretion of the provider to make sure that treatment response, if it can be delayed by 1 more month, or if it needs to be done at that point, then our radiologists are available to be able to accommodate our patients. And some patients' tumors can be followed by biomarkers or tumor markers in lieu of a scan to be able to tell us if the treatment is actually working or not. And one of the most important aspects of safety also includes our wellness as well as our patients' wellness. So we wanted to make sure that we continue to provide resources for wellness and stress management for our patients. We developed an FAQ that is now on our website that's more related to cancer-specific questions. And I believe that there has also been a development of a breast cancer-specific FAQ that's also available online. Our supportive care, psycho-oncology, social workers, as well as Art for Recovery programs are still available, and they are being provided in a remote setting. And I also wanted to briefly touch on the healthcare workers and what we've done to keep them safe. We wanted to assure that there was appropriate personal protective equipment. I believe in late March, we were getting quite concerned regarding the shortages, especially of the N95 masks. And interestingly, and we're very grateful that there was outpouring of support from the community, and a lot of people who were affected by the fires and had N95s in their homes donated masks. And thankfully, we have not required any issues with restricting mask use or other personal protective equipment use. Patients, as of this week, are being tested prior to surgeries, and all patients who are admitted to the hospital are also tested for COVID-19. We developed a centralized resource and website to be able to communicate recommendations to healthcare workers, as guidelines changed quite a bit early on and continue to do so around PPE, the personal protective equipment, as well as the workflows as they change. Daily screening tools apply also to our healthcare workers. Prior to reporting to work, everybody is required to report whether they have any symptoms, including fever, shortness of breath, respiratory symptoms, sore throat, etc. So that appropriate triaging of their care also is addressed. We encourage telecommuting, as we mentioned, regarding video visits. There's limited on-site staff that participate most of the time in a rotating schedule. However, those of us who still see patients who require infusion appointments, we still are available for our patients. There are stay-at-home and return-to-work guidelines so that if a provider does not feel well, they can be reassured by occupational health that they should stay home for the safety of their patients and their colleagues. We also provided wellness and stress management for healthcare workers. We know from the data from China that a lot of the providers experience distress, anxiety, insomnia, especially if they worked in the front lines. And we certainly wanted to be cognizant of those distressful times. And lastly, for healthcare workers with children, we wanted to make sure that childcare resources were available. And UCSF Health made sure that this was something that we implemented early on. And as you can imagine, with shelter in place, a lot of the children are at home now. I just wanted to close with just saying how committed we are to your well-being during these extraordinary, challenging times. I mean, these are unprecedented, uncharted territories. Our priority will continue to be that we provide you with effective and compassionate care without sacrificing the safety and health of everybody. So I thank you for your attention, and I'm happy to answer any questions that you may have regarding quality and safety in the Cancer Center.
Thanks very much. That was really excellent. And I think everybody who's listening really appreciated that information, and so well put. Really a phenomenal summary. And when I was listening to you, I was thinking about how all of that has unfolded over the last, 6 weeks or so. And to see it all put together, it seems so much better and easier to digest. So it was just great.
Yeah.
For all of us to see that. So I'm thinking that we're going to do Q&A after each one, but I'm thinking that maybe what we should do is, because Manisha's things kind of goes together, or maybe we'll have Manisha talk a little bit, and then we'll stop for a moment and do some Q&A. And also I want to introduce Sarah Donahue, who's on, just raise your hand, who's our senior nurse practitioner in breast oncology. So Manisha, thanks.
Wonderful. Thank you, Hope. So I wanted to just share this. As Pelin mentioned, one of the core innovations that have been a part of the COVID response has been to create a separate spaces for patients who do present with respiratory illness or other symptoms related to COVID-19, where they can be evaluated safely. Respiratory screening clinics exist at all our various campuses, but the respiratory screening clinic actually just forms a small portion of our response and areas where the patients can be evaluated. So essentially, we have a centralized approach and a tiered approach to how the patients can be, patients as well as our healthcare workers can be assessed and evaluated. We have the daily screeners at the lobby. There's a COVID hotline where we do testing and triaging, and then there is a level of clearance and symptom evaluation that we do. And if needed, we also do some patient tracking. So the COVID hotline and triage is essentially open to all patients associated with UCSF. And a patient can call this number with with a question related to COVID, to try to get an appointment to be seen by a provider, to discuss if they have something that has changed since the last time they saw their provider. So it's kind of like a one place where all patients can go ahead and call and initiate access into care at UCSF for anything related to COVID. Now, from the COVID hotline triage, there are it has a group of nurses as well as patient navigators who go through a set triage of questions, and then based on the symptoms that someone may be having, they tier them into, based on their acuity and severity, they get tiered into how rapidly they should receive care and where they should receive care. If someone is having mild symptoms and not necessarily having any significant risk factors that puts them at a higher risk of deteriorating, it might be that the COVID hotline will say, continue to stay at home, shelter in place, and then call back, and we'll give clear instructions of when to call back and check in. If the determination is made that you should go ahead and get evaluated further, there are multiple options. So if you are relatively stable, the option that we are would be offered is a video acute care visit, where a time is set and a provider does, a physician or a nurse practitioner can do a video visit with you. If the thought is that maybe you're a little sicker, not sick enough to go to the emergency room, but probably need to have a physical examination done in detail, that's when you come to something called as a respiratory screening clinic. And we'll go a little bit into details about that. And the third tier is the one that Pelin also had mentioned, is the accelerated care unit, which is essentially the emergency room, but a separate area where they have, separate the patients who who would need respiratory isolation or special isolations while they are being assessed for COVID-19. And then we have a mobile testing unit where only the swabs are conducted. So it's at our Laurel Heights campus. I'm not sure if people are as familiar with the campuses. Essentially, it's in a way, a drive-through. It does require an assessment by a provider beforehand. You can't just show up there. But the expectation is that once you've gone through the remote assessment by a provider and through the COVID hotline, an order is placed already. You go there, you will see the staff there is appropriately in PP in personal protective equipment, so that they can, while you're still in your car, they can assess, they can collect the specimens, and then you can go your way. It takes about 10 minutes or less. And the graph here essentially shows that once we had the mobile unit open, we were able to test so many more patients or employees. Initially, it opened up for employees. Now it's open for both our patients and employees. And our capacity to test the number of people greatly increased. Luckily, as you can see here, is that even though we have this capacity, we are actually not maximizing on the number of people we are seeing. And in fact, that's decreasing as well. So a little more about the Mission Bay RSC, which is the Respiratory Screening Clinic. As you can clearly see, it is a team that really works together and is engaged. And I think that is the core of what a specialty clinic of this kind requires. We have obviously we have providers, and they're nurse practitioners or physicians. We have nurses, and the nurses work as a dyad with the provider. So there's always a nurse and a provider team. There are runners and escorts. We have escorts in the lobby itself, so that as soon as you enter the lobby, there is you are directed directly to the respiratory screening clinic if you have an appointment with them, or if you have symptoms that are identified that require you to be assessed by them. We have a great group of nurse managers and educators, and our front desk staff as well. Also, another thing that you'll notice in the picture is our uniform that we're wearing. Everyone, there is a lot of steps and precautions that are taken to ensure further safety of providers working here. And so everyone is asked to change into hospital scrubs when they come here. We do have a mask and an eye shield, and you will notice that that's not worn everywhere in the hospital. The reason it's worn at the respiratory screening clinic is because through the day we come into contact with enough patients who might have respiratory symptoms and may potentially have COVID. So that's the additional layer of personal equipment that we wear. And then we also wear gowns when we are interacting directly with our patients and examining them. This is, just to show that as part of the creation of the respiratory screening clinic, all this has happened in such a short phase that we had to plan to be able to expand pretty rapidly based on the number of patients we would see. Luckily, we have not gotten even to the yellow zone. Just to share, it's like the expectation was that this rapidity of going from green to yellow to black could potentially have happened even in the span of a week. So we are lucky that we have stayed in what we call as the green zone, and in fact our numbers are decreasing, where we have decreased our hours even further. So the surge plan, even though there was a lot of effort that went into it, we are grateful to say that we did not have to evoke or put this into practice.
Manisha, do you want to just mention the PUI term?
Absolutely, thank you. So the term PUI means a person under investigation or a patient under investigation. And this is essentially, it doesn't mean that you have the diagnosis of COVID-19, but anyone who's being considered for that diagnosis. And we use this number to guide the algorithms or the level of preparedness that we have to do and the number of resources that we need to allocate so that we have enough support for the number of patients that we would be assessing for this condition. So this is just a little more information. So like I was saying, the respiratory screening clinic, we have one at every campus. We have, at UCSF has multiple campuses. At Parnassus, where we have a lot of our adult inpatient stuff. Mount Zion, where we have a lot of our outpatient care. Some of our cancer center patients also go there for their infusion. And then at Mission Bay has a unique set of populations. We have our cancer center patients here. We also have our women's health, so our patients are receiving obstetric care, and then also our pediatric, especially the pediatric patients who get subspecialty care. So if you look at these three big populations that are here, they all are considered to be immune compromised to some degree. So the role of the Mission Bay RSC was a little different, and the charge was a little different from the other RSCs, is to, one, obviously decompress the emergency room, that's the ED, find a place where these patients can be assessed, but at the same time, create a space where people, PUIs, people under investigation for COVID-19, can be assessed, evaluated, and treated separate from our immunocompromised patients going for their regular appointments. So while our goal is to have every patient have an appointment beforehand, either through the COVID-19 COVID hotline or through assessments by their providers, and get time slots so that we don't have a large gathering of our patients waiting for care. There are still patients who we might find out only once they reach the lobby or reach the hospital that they have symptoms that we should assess and investigate. These patients are also redirected to the respiratory screening clinic so that they can be quickly assessed for symptoms and evaluation further. So who gets testing for COVID-19? It's not, we haven't gotten to a point where we are testing everybody. There are few categories of patients that we're testing even before they have symptoms, but essentially it is patients who have a symptom that may be related to COVID-19. And like Pelin was mentioning earlier, that initially we started off only thinking about our lower respiratory tract symptoms. And then over time, we have realized that there are other symptoms, even though less likely than the respiratory symptoms, but maybe the only symptoms that our patients might present with. So we've expanded this group, and then having symptoms, but if you're doing fine otherwise, might just require you to stay at home, because it won't change what we can do for someone in terms of besides the supportive care of fever control and hydration and rest. One thing that changes things is if you have additional risk factors, and this is where our patient population definitely is unique, where there might be environmental risk factors, so travel history, healthcare workers, people living in congregate setting, or people living with immunocompromised patients, or if the patient themselves is immunocompromised. And like I mentioned before, patients with who are pregnant or have some chronic illness that can increase their risk of severe illness in case they do happen to contract COVID-19. Now, how do we go about testing these patients? We essentially look for the viral genes through PCR, which is polymerase chain reaction. It's essentially a way to look for specific genes that are related to the virus. And the good thing that we have is that our tests actually are very specific. So this diagram basically shows the different parts, and what we are targeting with our main test is the RNA, or the core protein developer portion of the virus itself. And so we have this PCR test, and it is very specific, actually greater than 99%. Even though there are different types of coronaviruses, the COVID-19, because it specifically targets parts of this very virus, if the test comes back as positive, the chances that you have the virus is essentially greater than 99%. The issue comes up is that it may not be catching every single person who has COVID-19. So if you look to the right, it shows the samples that we collect are through the oral as well as the nasopharyngeal cavities. And then if we are just collecting the oropharyngeal or just the nasopharyngeal swabs, the sensitivity is about 76%. So if you think about the nasopharyngeal swab, it's only 1 out of 4 people might be missed as having COVID-19, even though they actually do have it. The numbers obviously increase as you collect multiple samples. So the things to think about with this, and that's where our having a group of providers who are specifically thinking about patients presenting with these various symptoms, so that you're more familiar with catching the diagnoses. At the Mission Bay RSC, we work really closely with our cancer center physicians and providers because we want to make sure that the symptom that someone is presenting with, it may be a symptom related to their underlying condition, but it may be related to COVID-19. And so it is, there is a lot of communication that happens back and forth between the primary subspecialist as well as the RSC provider. One thing that I didn't mention is usually when you think about an urgent care, it's usually primary care providers who staff the clinic, and at the Mission Bay RSC, where most of our cancer center patients come, it's actually oncologists as well as obstetricians who staff this clinic. And so they definitely have much more knowledge about how the treatments that someone might be for their cancer diagnosis, how that affects their symptoms. So just a couple more slides. The one thing that I wanted to kind of mention again, Pelin mentioned as well. Now, for our patients who are being identified to have COVID-19, we actually have a special clinical management team at UCSF. It consists of nurses as well as physicians, someone who's on call every day, and we are regularly monitoring and evaluating any patient who has been diagnosed with COVID-19 through UCSF, but is at home. So we check in with them through an initial triage on the phone. You get to speak directly to a nurse. And then once that is set up, every 2 days you get an automated call, because patients can get sick a few days into their illness. And so we want to make sure that we're staying ahead of the symptoms and escalating the care of our patients, asking them to come in if their symptoms are worsening. And then that brings to the other end of the spectrum as to as we are recovering, especially for our patients with chronic conditions who need to return to their treatment, return to the clinic and infusion center, we have criteria that have been developed along with infectious disease as well as infection control. Our cancer center physicians have been instrumental in creating these guidelines together. The group was being led by Dr. Cinar. And one of the main things that we're thinking about is a person will be cleared from their isolation or to be able to return to the hospital based on certain symptoms being resolved. However, for our immunocompromised patients, this would likely include a repeat COVID test. And the reason is because sometimes our immune compromised patient can continue to shed the virus for a much longer time than someone who's not immunocompromised. And I think I'll stop there.
Great. I love your last picture there with the little mask. Very cute. He needs a specialized sized mask, I think. We're also, just want to introduce our last speaker has been able to join, finishing with clinic, Dr. Laura Esserman, who's the director of the Breast Care Center and co-lead the breast cancer program, was in clinic, of course. So, so we have a phenomenal panel, and you've heard from two, and I want to give you time to hear from everybody else. But I thought what we'd do is do a few questions that have been coming up and have been sent in ahead of time. One of the questions I think that is interesting and could be useful for people to know about is whether infusion center nurses who come into contact with immunocompromised patients are also prohibited from working in the ICU or emergency room. So are they working in several different places? Also, I think another question that's related to that is that whether or not the nurses are actually screened on any regular basis or the providers. And you did talk about how we do that screening already, and I think that's just maybe worthwhile to summarize again how you're managing that in terms of being able to make sure that staff are not communicating infections to patients. Pelin, do you want to briefly manage that?
Sure, absolutely. Just to address the first question, our nurses in the infusion center do not rotate in any other disciplines. And we have not had the surge that would require any of our staff members to be distributed anywhere else. So in that regard, there is no concerns. And as you know, we now have universal surgical mask, meaning that whenever you're anywhere in the clinical areas, you're required to wear a mask. So that certainly will reduce the exposure risk. The second question is in regards to screening. So prior to coming into the clinical areas every day, everybody, staff members, healthcare providers, whether they're RNs, NPs, or MDs, are required to answer specific questions as they relate to concerning symptoms of COVID-19. If there are any questions, questionable symptoms, then they are referred to the respiratory screening clinic, for example, to be able to get tested. And if they do not have any symptoms, then they're cleared to work for that one day. And yet they're still required to wear a mask as well, even if they don't have any symptoms. We're all required to wear masks now.
Sarah, do you want to briefly mention what you do for the patients who have the automated call-in screen positive? I know you've been doing a lot of screening for our patients who come to clinic. You're on mute, just so you know.
Can you hear me right now?
Yeah, now we can.
Okay, good. Sorry. So before a patient comes in for a clinic visit or to the infusion center to get an injection or chemotherapy, they're going to get called by a nurse, and the nurse will ask them if they have any symptoms or have had any contact with anybody with COVID. If any of their questions are positive, then the nurse contacts me and our nurse manager, and then I call them, one of the nurses, nurse practitioners will call them, or even the attending will call them and go through their symptoms through a video visit. And if we feel that there is something still that is concerning, we can then escalate it and send them to the RSC or send them to the COVID hotline and follow the steps as Manisha explained.
And actually, that's, I think, worked really well because patients, we had somebody who screened fine one day, but on the day she was supposed to come in, she developed a sore throat, and she called, and she knew to call from her screening before, so we actually delayed her treatment and had her come in to be tested, and just to be sure, because we're being very careful about exposing our patients and our staff. Thankfully, she screened negative, so that's all good. And she just had a little sore throat, and it's allergy season, so it's really a challenge. So. We have a bunch more questions to talk about here with our great panel, but I'm going to pass the microphone on to Laura Esserman, who is going to talk a little bit about how in the Breast Care Center we've been thinking about managing patients with early stage breast cancer. I'll talk a little bit more about the metastatic setting briefly with Sarah, but I think, Laura, a lot of the questions that have come in have been about when people can have surgery and how long it's safe to delay imaging. Is 3 months okay? Things like that, along with what you cover.
Yeah, thanks. Actually, I was going to actually even ask a question right before I started, because this came up for one of the patients that I saw this afternoon, where her son, she has cancer herself, and her son is coming back from New York, and she is pretty sure that he had COVID. He was really sick, and everyone in his group of friends got sick, but they didn't get tested, and he's put himself in quarantine for 3 weeks. But I think the son wants to know, and she wants to know, does he have an antibody titer? And what's our policy for being able to get people antibody titer tested, especially if someone's getting chemotherapy and they're immunosuppressed? How are, what are, and, I mean, even if someone's recovered and so on, that the ability to do that's going to be important. And certainly that's going to be important for everyone getting back to work. So I thought I might start with that, and then I'll talk about what I've been assigned.
So I know that antibody testing is something new, and Pelin actually talked about it a little this morning. So I think that it's worthwhile to have Pelin start with that, and Manisha certainly add in anything if you want. And I think also just testing somebody who had those symptoms who didn't get tested. This was a group of young men, and one of the people was tested and did have COVID, and they all worked together. And so then he eventually came back and has sheltered from the family member. But I think one of the questions of family members is, when is it safe to be back in touch with that person? What do I do? So
yeah, all great questions. So I'll touch on the antibody testing. So this is actually something that we're doing. We're still sending it out, the last I heard from our infectious disease specialist. So it doesn't have a very quick turnaround time. But all of these scenarios would be great examples of how we could potentially use the serology or the antibody testing. The challenge that infectious disease has brought up is, once we know that information, how can we actually implement it? And some of the scenarios could be exactly similar to this case, where the son, for example, had symptoms and very high suspicion of having COVID. And right now, if we tested him, he may test negative if he doesn't have as much of a viral load. But that would have been a perfect case of doing the antibody testing, because we would now know if he has developed immunity to it. Similarly, for our providers or staff members, etc., if they had symptoms and they were mild or they were even asymptomatic, we could potentially do this before they are faced with treating our patients. In regards to testing our asymptomatic patients for systemic chemotherapy at this point, we actually had this discussion this morning with our physician champions and some of the leaders in the cancer center. And at this point, we're only going to be testing the high-risk patient population who are asymptomatic. For example, those who may be joining us from convalescent living situations, such as skilled nursing facilities, shelters, etc., where there has been outbreaks. So we're going to have a low threshold for testing those patients. With systemic therapy like chemotherapy, targeted therapy, and immunotherapy, at this point, it's not standard practice. However, from my discussions with infectious disease and our ambulatory directors, we will be addressing it again middle of next week, after we have a little bit more data from what we've seen with testing of asymptomatic patients who are going in for surgeries, for example, or who are being admitted to the hospital, just so we have a good understanding of what % of our asymptomatic patients in our shelter-in-place community are we going to be seeing to test positive. And then I think there was one more question.
Can someone who is highly suspicious, especially if they're going to be with someone who's at risk, get serology testing?
So there is actually, yes, they can definitely do that. And we do actually have guidelines even without the testing, So non-testing strategy for our patients who may have a COVID positive cohabitant or a family member they live with. What do we do in those cases? And we try to be conservative, where we mention that it's the 14 days from the last contact with that patient, or if the patient requires treatment, then we have guidelines in place where we can actually treat them, considering them at being at high risk of COVID-19. So the staff would require a full PPE. For that, they would be treated at the respiratory screening clinic to get their infusion rather than going to the infusion center to get that treatment. So there are definitely multiple different ways that we can handle it. At this point, we have the luxury of having only a few patients who fit these scenarios, so we're able to actually evaluate them on a case-by-case basis.
That's really helpful, I think. One of the things, Laura, that and you know, this is a changing area, as I was mentioning earlier. I mean, there's just a new bit of information that we have every few days and sometimes every day. And we're really, I think everybody's really out there to protect our patients as much as possible. Laura, one of the things also that might be helpful is just to talk about briefly, because we want to have time for more questions, is that also one of the questions that's come up some is, besides the, you know, how long can you wait to have surgery for your breast cancer newly diagnosed? How long can you wait with your imaging, and when you've had cancer before? And then I think something about medications, you know, using azithromycin or hydroxychloroquine, and what are we doing with medications? And I know you've had, I talked earlier about how you were working on a project with that.
I can talk about that for a minute. So I think the main, so I think that there are many safe ways to delay surgery. And in fact, it's so interesting that these interim guidelines that have come out from everyone very much mirror the way we've been practicing for the last 5 years. And in fact, our clinical trials, you know, a clinical trial is tomorrow's treatments today. And as a group, we have been very forward thinking about saying, if someone's got a big cancer, we don't like to operate on them first, because surgery isn't the answer for curing someone with a large cancer. Systemic therapy is, you know, that when someone's got a risk of dying, potentially dying of their disease, it's not because it's in the breast. So whether we like to use the molecular tools to interrogate the tumor, what kind of tumor do people have? If it's fast growing or mammogram high or oncotype high, we know we want to start with chemotherapy. And we think that's the right thing to do, because it helps us figure out whether the treatments we have are working and gives us a second chance to optimize that therapy. And the better they work, the less surgery people need. And so we can right size the amount of radiation, or if it also helps us avoid radiation if people don't need it. So there's lots of reasons why we think that when you first come in with a new cancer, that surgery first isn't the right answer. We've been doing that for years. So starting with hormone therapy is also a good thing to do, or a safe thing to do. If someone has an in situ cancer, it's not an emergency. Your life is not on the line. If you can treat with hormonal therapy for invasive cancer, certainly you can do it for DCIS. So there is no harm in starting a treatment and doing a systemic treatment for 3 months. So this particular time, this doesn't create a crisis for us, because that's our standard therapy anyway. And we feel that we learn so much more about every person's tumor, and it allows us to personalize their therapy in a good way. One of the reasons why we've delayed, we all made this decision to stop operating and delay, was a couple of reasons. It allowed us a chance to stop, pause, understand how much risk this pandemic was going to cause. As you can see in New York, it completely overwhelmed their systems. They had in Columbia Presbyterian, they had 500 people in the ICUs. All the ORs were turned into ICUs. And, you know, so we didn't know what was coming. So the thing that you need to do to be able to do everything safely is make sure you have personal protective equipment. Make sure that you have a plan for how to properly test people. You know, there's a risk when if someone has COVID, if they're put to sleep, the active anesthesia can be risky. So it's important to know if they do. Plus, it's an easy way to spread the virus to everyone in the room. So all these measures had to be put into place. So it's not that there isn't going to be surgery ever when the peak finishes. I mean, again, someone coming in with a new cancer, doing something for 3 months is already our standard practice, so it's not putting anybody at risk. Surgery is resuming already for the highest risk cases. I mean, we didn't stop operating on our highest risk cases, and we're taking back the people in that more urgent risk. And, by June, we'll be, I expect, back at our normal, in our normal pace. We are actually testing everybody. Starting this week, we started testing everybody who is going to the operating room, which I have been calling for from the beginning. I think the only reason why we all had to put a pause in, we had to kind of get our act together, make sure we had enough testing, make sure there was enough equipment, make sure there was, a plan in place, make sure that people had retooled and thought about how do you safely intubate the patient, how do you do intubations and make sure it's safe for all the staff, all of these things. So I think that as we get back to work and as we're going to do this, the people who actually have serum antibodies, we will know that they have been exposed and they're like got a TSA pre-check, but the rest of the people coming in, there will be some way, probably of, testing in an ongoing way. So that's the story about a new cancer. So it didn't, in situ or precancerous lesions, I have an active surveillance study where I've been following people, and I think the response in the first 3 months is actually really helpful to try and find out who needs surgery ever. So I think that's a good thing. And we also have a trial where if you have one of the riskier DCIS that's hormone negative, we actually have an immunotherapy trial where we can inject the tumor itself, and we know that really helps the body, respond with a more robust immune response. So we're 100% prepared to make it safe for everybody in the time for breast care in the time of COVID is very safe. Now, what about screening? So there really is no harm in delaying for 3 months, and it really will be March, April, May. In June, as it turns out, we just got the notice this morning that radiology is resuming their normal schedule for screening starting in June. I think the second week of June. And that really will be just about 3 months. I think that, for a lot of people, cancer is, when people find out they have cancer, they feel like it's an emergency. But cancer is an emergency because you know about it. You could have gotten the MRI 2 months later or 3 months later. That 2 to 3 months is not what makes a big difference. In fact, for the tumors that are super risky, that are big, if you feel a mass, don't wait for a mammogram. We still are taking care of people who have a new symptom or a big mass. I just saw someone just now with a big mass who did come up. We're still doing mammograms. We're still doing biopsies. We're still doing the things that people absolutely need urgently. What we're trying to do is during this period of time where we're trying to shelter in place, and as you can see, I think George Rutherford said that we probably saved 44,000 lives in California by our very aggressive sheltering in place. So we are trying to work within those guidelines to keep everybody as safe as possible. And, as everybody who's had cancer knows, everything is a trade-off, and you have to make decisions about trading off safety in one area versus safety in another. There is no harm in 2 to 3 months of something where you're asymptomatic and getting a screen. That is okay. But what we tell people is if you have a new mass or something new is wrong, we want you to come in. And so that's really important.
So one of the things I think that and I want to hear from Sarah too here, is somebody asked about whether or not if everybody is wearing a mask and washing their hands and nobody's sick, do you have to keep 6 feet of separation? And that was an interesting thing. And we want to do that in the community at large. So for example, in the grocery store, you want to keep your 6 feet of separation and wash your hands and avoid touching your face, which is a key thing because you can't get anything from your hands on anywhere unless you touch your face. So
okay, I put my hand down.
Yeah, I know, really. It's so funny because when we're talking on the phone, you don't realize until you see yourself on Zoom how much you're touching your face all the time. So it's been really a lesson for all of us. But I think in the clinic where we're seeing patients and everybody's been screened, we're always wearing a mask. I happen to be in a clinic room, but I'm not wearing a mask because no one's in here with me. But I'm all by myself. But
I'm right on the other side of the door, Hope.
Right, I know. So that's when we're all by ourselves.
6 feet away.
Yeah, when we're all by ourselves, it's okay. But I think otherwise, the only time we're closer to people is when we're doing an exam or, for example, your nurse in the infusion center. And those are just, everybody's, again, being screened and we're taking a lot of care. I think the remarkable thing is that with everything that you've been hearing tonight is that we have not had a single patient get COVID from being in the cancer center. I mean, so we just don't have that information. We've been able to identify a lot about people who have been infected and where they get it from the community. Even some people who work in various areas in hospital settings, it's been primarily community acquired. So I think that that's really helpful information.
Well, I think we've tried to proceed with an abundance of caution and to be as safe as we can. And the good thing is, once the virus passes, and if it can't pass from person to person and the wave of the virus goes away, the chance of transmission will be lower and lower and lower. And that's the tail. That's the reason why we're still waiting for that period of time. But that 3 month window is really, I think, going to pass, and people will be resuming sort of their normal screenings in June. And by the way, I would recommend, most of you already have cancer, but don't forget, our trials are open. Actually, I actually feel that clinical trials are an essential part of care. We have not stopped the I-SPY trial because we believe that the treatments that we have are hopefully better than that appear to be better than some of the standard therapies. And we want to make sure that people with serious cancers can be offered that. The Wisdom study, which is our screening study of personalized screening versus annual screening, is still open. So I would tell everybody that hasn't had breast cancer to sign up for the Wisdom study while they're home and sheltering in place. What better thing do they have
use
to
of
do
your
than
time?
to sign up?
No, it's a good thing. And I think that another question that came up that I definitely want to discuss is the medications. But before we do that, I just wanted to hear from Sarah a little bit about your experience with telemedicine. I think we're all really excited about the fact that we've been able to talk to our patients and communicate with them during this difficult time without bringing them in. Of course, I treat a lot of patients with chemotherapy because of the nature of my practice. So those patients have been coming into clinic with all of our care that you've been hearing about. And so far that's gone extremely well. And we've been doing it now for about a month, and it seems to be still going very well. But we've converted everybody who's taking oral medications and who can be treated at home through these telemedicine visits. People are getting local laboratories. And I'd like to hear just, Sarah, what your experience has been with that. You're on mute still.
Sorry. You can't.
Now we can
hear me?
Yep.
Okay. So I've been doing a lot of telemedicine visits in the past few weeks, and it's surprising how much you can get done through a telemedicine visit. You don't realize how much of the time in a room with a patient is just talking to them and understanding what their symptoms are, and helping them treat their symptoms, and making plans for evaluating them on scans next, and talking about the future. So the visits have been going really well. The only missing piece is the exam, but we can do a lot of it. You can look at somebody's face and you can see that they're well or unwell. So yeah, it's been a really great experience, I think, for me. And I think that it's been effective, and patients have a moment to be heard by their nurse. And so, yeah.
Yeah, I think that's really helpful. And for our patients who have advanced disease, metastatic breast cancer, we've gotten some interesting questions as well. And I think, a big question is if you're on oral medication, and you're doing well and we can get labs, we try and keep you away from clinic. But a lot of our patients, high risk, early stage and metastatic disease are getting injections to suppress their ovaries. And we feel like it's important to keep that going because the treatment doesn't work otherwise. But we have been trying to limit coming in for treatments that we feel can be delayed. So for example, your screening mammogram can be delayed, your bone medication can be delayed unless you have problems with your calcium. So that's something that we've been doing and trying to really delay for a while. Your bone mineral density can be delayed for 3 months or longer and there won't be any difficulty. So, but when we're trying to evaluate somebody who has back pain and we need to get scans, we've been able to get those scans in a timely manner. And then I think that another question that came up was, should patients who have metastatic disease who've said they don't want to be resuscitated at home change their DNR status because in case they would be ventilated? And I think that it's really important for your family and your providers to know your wishes and to fill out your forms with as much accuracy as possible. So you can actually fill out forms, these forms that we call posts that will discuss the fact that you want to be resuscitated if it's something that you can be saved from, an acute infection, for example. So you can qualify your what you want, your own wishes for end-of-life care or when you have an acute problem. It doesn't have to be an all or none. So I definitely encourage you that that's not an issue. One of the questions that another came up because we do a lot of scans and we have people coming in for treatment. So two particular questions, which is one, if we know that cancer patients are more immunocompromised than other patients, even if their cancer treatment was many years ago, and what we know about the immunocompromised state. And there, maybe a few people would like to comment on that. But the second thing, which Pelin, maybe you would answer, is the question about getting scans. How clean is it when you go and get a scan? How safe do we think it is? People going for radiation, for example.
Yeah, so although those patients go through the same screening processes, and if, let's say, there needs to be a patient who is COVID positive and their treatment cannot be interrupted because they're in the middle of their radiation therapy, there's actually very strict guidelines that were developed. For example, they come at the end of the day when there's no other patients around. A limited number of core team members take care of them. And immediately after they leave, environmental services comes and cleans the room. These are all in an effort to reduce the number of touch points for that patient who may potentially be an exposure risk. So environmental services and the care teams are in very close coordination to keep the areas safe.
In our clinics, actually, our medical assistants have been taught how to clean the rooms very carefully, even the keyboards and all of the different things that are touched so that people can't convey the virus from one place to another and have it survive. So, there's been a lot of discussions on the web about that, and I think it's worked out very well here where we felt very comfortable with this. And I think that, for cancer patients, the risk in terms of understanding what the risk is for cancer patients is confusing because with a lot of the data we have is from countries where care is provided in a very different way, where population density is quite different, and where access to care, in addition to how care is provided, is quite different. So, I think for us, we really haven't found that patients who are far out from their cancer diagnosis are more immunocompromised in terms of getting the flu or any other infection. And during treatment, most patients with breast cancer who aren't on chronic steroids or have other reasons to be immunosuppressed seem to have a reasonably intact immune system. We've talked a lot about liberalizing the use of growth factors so that we don't allow patients to have too low a white blood cell count, and that's part of the national guidelines now during COVID. So there are a lot of ways that we're trying to get around that. Pelin, do you have any comment on that as well?
No, I agree, Hope. I think some of the data that came out of China was quite limited studies. They were small group. I mean, there was like 18 patients with cancer. When they looked at those patients, they had a lot of other medical problems that may have contributed to the complications that they may have experienced. But I agree. I don't think we have a good sense of what our population in the U.S. and specifically in an area like San Francisco, where there doesn't appear to be as much of a community acquired transmission, where the percent of positive rate is quite low. That I think luckily we can say that, and we can be reassured that our cancer patients who are far out from their treatments are not as immunosuppressed. But as you mentioned, even for those patients who are getting their chemotherapy, which may result in some immunosuppression, we have found different ways of helping them out, like the growth factors. For bone marrow transplant patients where they're very immunosuppressed, they actually undergo very different types of screening processes.
I think that, yeah, okay, good. I was muted briefly there. So I think that's really helpful information. And one of the other, and I think somebody just asked a question about that we really don't consider people who have had chemo 2, 5, or 10 years ago persistently immunocompromised, and that's not really an issue. In terms of treating patients, there's been a lot of interest in whether or not people should keep anti-malarial drugs around or antibiotics, and then there was just some publication about remdesivir, an antiviral medication. I think that we're still in really early stages about that. I know that Laura has a lot of interest in ways to test that. I don't see her video is on now. And I'd like her to comment on just how we're going to investigate that, and then maybe have Manisha or Pelin comment about whether anybody should be thinking about buying those drugs now.
Well, I 100% do not think that people should be taking chloroquine or remdesivir or any of those things yet, because we don't know. We don't know the answer. I'm a big believer in learning and learning fast, but I'm a big believer in doing it in a way that you know an answer. Just doing stuff does not help anybody. Doesn't help the patients, doesn't help the community. We actually, I have been working with Carolyn Kelfie and Kathleen Liu, pulmonary critical care people. One of them, Carolyn, had spent a year sabbatical working with the iSpy group and learning how to run or develop an iSpy-like trial or a platform adaptive trial for the ICU. And so I called her a couple of weeks ago and I said, well, it seems like now's the moment. And it turns out that there's a consortium, this COVID R&D consortium, that has committed all of these repurposed drugs like Otezla, those horrible commercials. I think if it works in ARDS, I'm going to say you got to take the commercial down. Anyway, but there are, it's so interesting that in November when we went to the NIH to talk about this, they said that there were no drugs. Now there are like 63 of them. It's just that nobody wanted to give their drugs for acute respiratory distress syndrome. But it turns out that there are 3 classes of drugs. They're the antivirals, like that have been used for AIDS, and there's new ones, and there's kind of new ones that rescue people. Then there's the kinds of drugs that we call that are anti-cytokine drugs. So one of the reasons why people get sick and die is because their body reacts very badly to the virus, and they get this it's the opposite of what we want to see in cancer. Cancer, we're trying to rev up an immune response, but with something like the COVID virus, we're trying to tamp it down. And this will happen with COVID, happens with Ebola, it happened with the 1918 flu pandemic, or the next new virus, or if this virus mutates. So it's super important to get a handle on what kinds of agents can really tamp down that response. The interesting thing is that people have heard of, CAR T cells, and this is really, again, a super duper way of priming the immune system to attack a tumor. One of the problems with that is we only use it in the sickest of people, or people with a 90+% chance of dying, because the response to these drugs can be the super duper response by the immune system, which they call the cytokine storm. So the idea is, what can you do to stop that? Well, it turns out that there's several drugs that are available for that. Now, they're very expensive, and of course, you're not going to charge that in this kind of a setting. So I think it's really an opportunity, and I'm amazed to see the pharmaceutical industry coming together, and they're coming together to solve this, not because they want to sell their drugs for ARDS. Everybody knows that's not a big moneymaker. Everybody knows, but everybody does know that if they don't solve this problem, and we don't have a way to treat people who are critically ill and keep them from dying, life as we know it may not go back to normal. We won't be able to go back to doing drug development and lots of trials and all the things that we like, and big meetings and all those kinds of things. But if in fact there was a way in which we could decrease the death rate or the time on the ventilators and all those acute problems that people get when they get ill with the virus, that would go a long way to making everybody feel so much more safe, and we wouldn't have to shut the economy down every time that there was a pandemic. So if ever there was a reason for everyone to come together and unify and work on a platform trial where we could learn in real time, this is it. So we are working on that, and we are fortunate that we have a network, our iSpy network, that can probably bring this up in real time by just moving it along, and that's what we're trying to do. So we'll see in the next 2 weeks if we can stand up a trial to help the pulmonary community stand up to do that trial. And I think everyone's willing to put their best effort forward, because nothing could be more important.
Yeah, I think that's really important, because I think trying to, work together to study these issues is critical. And there have been a lot of international web panels for physicians, and now there's been a lot more focus on patient education as well. In particular, these treatment issues are really big, because patients have occasionally taken these medications on their own and had really very high risk and fatal complications. So
yeah, the Brazilian trial, actually, the high dose chloroquine was stopped, despite what's been said in the presidential briefings. This is not he is not going to get the Nobel Prize in medicine for prescribing chloroquine. This is not something that everybody should go out and take. There is no good data that says that is so. Let's wait for evidence here.
And I think that there's a lot of people are using these medications now in clinical trials earlier. There's also a lot of data that's being accumulated. And one of our research coordinators is actually working part-time on a study where serology will be checked at a variety of intervals over a 6-month period to see about healthcare workers and who's immune, because as you've seen in the news, this is a virus that's not going to go away, but we're hopeful that it will retreat back under the covers, at least to some degree. Yes. And understanding who's immune as we move forward and what serology means is really important. So these studies which are going on are critical, and it's all a cooperation with everybody trying to work together as a really large community. One of the questions that came up, and I think we hear this a lot, and Manisha, maybe you could briefly comment on this, is if there wasn't a shortage of N95 masks, would that be the recommended mask for everybody to use? Would that be the best way to prevent the infection?
So I would say that it's not the mask alone, because the way this virus works is that it is transmitted by the larger respiratory droplets, for which a surgical mask is sufficient. When you have a situation where these respiratory droplets are aerosolized or made to travel further, and that's when we talk about sampling, that's when we talk about patients getting a respiratory treatment, that's when you need something like an N95 mask. If, I think more than anything else, if we were able to keep our distance of like greater than maintain more than 6 feet of distance isolation, those would be ideal. An N95 mask is used in certain scenarios, like for example, in our emergency room, we use N95 mask for everybody, but that's because we are in close quarters. There are actively processes happening where patients might be having their secretions be put into the air more, what we call as aerosolized. Those are the situations where an N95 mask is needed. There was some study about the particles, viral particles, still being present in the environment 2 hours later, and that study was done in the setting in a laboratory where there are the centrifuge machines on, the humidity level is different. It's hard to extrapolate that information and put it into your natural environment. So that is probably where the previous information about this virus being aerosolized and staying in the air long has come from, but not how we would experience in our day-to-day life.
Right, and I think one of the ways that we know that this strategy is working is that the curve has flattened and it is going down. We've passed the peak and it is working. And so for those of you who haven't worn an N95 mask, they're hot, they're really uncomfortable. No one wants to wear one of those. And particularly we should, I really feel like it's, and you don't need a surgical mask, even a thick cloth is fine. And, those N95 masks need to be saved for the people who are actively treating people, and it's very important. And you shouldn't think, oh, but I'm going to keep one for myself. There's no reason. No one should be buying them, using them. Let's save that for the medical personnel. Nobody should want to have them, and there's no need for it.
The one other thing that I would say is if you have a reusable N95 mask and you see people using that because they might not have another cover, that is fine, but it's not because an N95 mask is needed. One other thing that I would mention about N95 masks is sometimes you see people wearing them and they have like a valve or a plastic opening at the mouth of it. The one thing that I would recommend also is that we get this false sense of reassurance if someone is wearing a mask, even a surgical mask, that we can continue to be close. I think even in those situations, it's important to keep your distance, especially with people who have the valve or that opening, the plastic valve on top of the N95 mask, because it might protect them from getting the droplets from outside, but it does not prevent their secretions and their exhale from being out in the environment.
And that's actually a really important point. I'm glad you brought that up, Manisha, because, I see all these people outside with the masks that have the little, like they look like a little respirator on them, a little filter, and people feel like, oh, it's so much better. But in fact, it's not much better. And you can infect everybody around you if you cough, through the mask. It comes through the droplets. So that's really a big issue. So as we just have a couple of more minutes, so I wanted to have everybody just have a chance to say a last brief comment. Sarah, do you want to start? We'll see if you get off.
Can you hear me?
Yes.
Okay. I think that a lot of patients for me that I've been seeing have been addressed, like asking the questions that we discussed in the forum. So I'm really glad that we're having this right now to answer these questions for them. I don't really have much to add other than I'm excited to be out of this soon. And the patients, just thank you so much for bearing with us and being patient and kind. And we'll see you in clinic soon.
Amen. One thing maybe you could just mention with this is like, how do people exercise outside? How do they stay away from people?
Pelin or me?
No, for Pelin, yeah.
So I think that it's still important for everybody to be out and about. As long as you keep a safe distance between you and other people, you should be okay. And if you feel like you're you may not have that protection of being 6 feet or further apart from another
What's your
person.
medical record number?
Make sure that you wear a mask when you're doing your exercising. Clearly, we're still in shelter in place, so it's not like you can go to the gym and work out, but it's nice to get out. I think for both physical and emotional well-being, it's important. I guess my closing remarks is, I think we all realize that it's really a distressful time with a lot of uncertainties for both our patients as well as our providers and healthcare workers and our colleagues. But we just want to let you know that we're here for you. If any questions come up, concerns come up, feel free to reach out to your care team. Just know that we're committed to you and your well-being.
And Manisha, do you want to make a final comment?
I would say that, just keep the questions coming, because I think a lot of anxiety and fear can come from misinformation and assumptions. And besides this forum as well, it's my first time. I'm just amazed at the amount I have learned, and I'm very appreciative of the questions that have come up. So I would say, please keep asking those questions. And in relation to the respiratory screening clinic, also there can be a lot of anxiety related to it. They've done studies where both providers, like the providers who work in these places, actually potentially feel much more safe from a protection standpoint, because they're consistently wearing the right PPE, even though they might be coming into contact with higher risk patients. So it allows for more consistency and less errors. So that's another reassurance that I would give.
Laura, you want to make a final comment?
Sure. I just want to make sure that everyone understands that we're all here for you. We haven't closed the clinic. We haven't closed most of our trials. Care is here for anyone who needs it. Unfortunately, we're having to do it in slightly different ways, but some of the ways that we're learning how to do things, by doing video visits and doing things that maybe even be more convenient, good things will always come out of crisis, and we'll learn how to do things smoother, better. But know that we are here for you. And if anything goes wrong, or just a phone call or an email or a my chart away. So don't feel like you're being left hanging. Everyone's here to give you the best possible care, and we'll all manage regardless of the circumstance. Rain, sleet, or shine, we're here.
Indeed, thank you. And as we close now, I want to, first, of course, emphasize, reiterate everything everybody has said. Our patients have been amazing through this, and, navigated through using Zoom, and we are still working on providing the very best care we possibly can. One of the big questions that has come up from patients internationally really is, how much is my care suffering? How much is my survival suffering? And I can really say quite confidently that we have not compromised anybody's care in a way that would impact their survival or the risk of recurrence because of COVID-19. And the reason why we've been able to do that is because of the incredible team that is present at UCSF. The people you heard speak today donated their time after working already very long days starting early in the morning, have worked 7 days a week to make sure that we're all safe in the UCSF community. Our staff, our nurse practitioners, have continued to work very hard, as have our schedulers, our nurses, our triage nurses, everybody. And they're working from home 10 hours a day, making sure that they convert visits to video calls. So the group of people here has been amazing. I'm excited that we haven't compromised care. And looking to the future, I think that this can only result in a better way of providing care in the future and more knowledge. I want to thank Melody Galu, who also, maybe you can come on video, Melody, has donated her time to make sure the forum continues and coordinated our very first ever Zoom forum, which we hope to continue forward. And we're very, very grateful to your time. I want to thank Pelin, Manisha, Sarah, and Laura for donating your time this evening. And we look forward to seeing everyone who participated at our next forum. Stay well, be safe.